All right, so let's dive into this case together. We have a 3-month-old baby presenting with heart failure, and an MRI has been performed to get a closer look at what's going on. Heart failure in a baby this young is always a red flag, and you know it's time to be on the lookout for something significant, particularly involving both the heart and the brain, given how intricately they're connected. Now, when we review the MRI, we can immediately see some concerning findings. First off, on the axial and coronal T2 weighted images, there's a midline posterior mass that's hypointense, indicating a signal void. This signal void usually suggests the presence of a fast-flowing structure, which in this case is a large vascular anomaly. Not only that, but there's also mass effect on the surrounding structures, which isn't surprising given the size and location of this lesion. You can also see enlarged, tortuous vessels encircling the mass. This abnormal vasculature is key in understanding the pathology we're dealing with here. Now there's more. The lateral ventricles are dilated, which indicates a secondary development of hydrocephalus. That's not uncommon in these cases, as the abnormal venous drainage can cause increased intracranial pressure, leading to ventricular enlargement. When we switch to the sagittal T1 weighted image, we see a serpiginous, hypointense structure running along the line of the vein of Galen and extending to the superior straight sinus. This involvement of the vein of Galen and its proximity to the superior sagittal sinus and torcular hierophily is another big clue. This abnormality is displacing the tectal plate inferiorly and narrowing the cerebral aqueduct, further contributing to the hydrocephalus. Next, we have a maximal intensity projection, MR angiography image, and here we can see the full extent of the situation. The serpiginous flow voids are not only affecting the vein of Galen, but also extending into the straight sinus and torcular, with multiple tortuous feeding vessels. There's also ectasia of other arteries, which is telling us just how extensive this malformation is. So, piecing all of this together, what we're looking at here is a case of vein of Galen aneurysmal malformation, a rare and complex congenital vascular condition. Now, let's break this down a bit more because vein of Galen aneurysmal malformations are important to understand, especially in pediatric radiology. These are rare congenital malformations, but they account for about 30% of all pediatric CNS vascular malformations, making them the most common in this category. In terms of what causes this malformation, it develops from an arteriovenous fistula in utero, usually between 6 and 11 weeks of gestation. This abnormal connection allows high-pressure arterial blood to flow directly into the embryonic vein of Galen without going through the normal capillary bed. The result is a significantly dilated vein of Galen, which is what we're seeing here. Importantly, the vein of Galen is the median vein of the prosencephalon in the embryonic brain, and there's no connection to the deep venous system. These malformations can be classified into two types: the choroidal type, which has multiple shunting points and unobstructed venous drainage, and the mural type, which has fewer shunts and more restricted venous outflow. The type and extent of the shunting help determine how early and severely the patient presents. In this case, with such a large malformation and secondary hydrocephalus, it's not surprising that this baby is presenting with heart failure. The high-output cardiac failure that results from the excessive shunting can lead to severe complications if not managed early. Historically, this cardiac failure was often the cause of death in these patients before the advent of endovascular treatment. Now, when it comes to treatment, endovascular embolization is the preferred method, where interventional radiologists can target the shunts and decrease the flow through the malformation. This helps reduce the cardiac load and can prevent further neurological damage. However, it's not without risks. The embolization procedure can lead to complications such as aneurysm perforation, cerebral infarction, or even migration of embolic material to distant sites. In some cases, like the one we're discussing, prenatal ultrasound might already raise suspicion if severe heart failure or signs of hydrops fetalis are present. Further imaging, both ante- and postnatally, is crucial for characterizing the malformation and assessing the severity. On MRI, the hallmark is that large midline signal void we saw, which corresponds to the vein of Galen. And when we see feeding vessels, like in this case, they show up as serpiginous flow voids. Given the complexity and severity of this malformation, ongoing monitoring and multidisciplinary care are essential. This includes both neurovascular and cardiac specialists working together to optimize treatment, whether that's through endovascular intervention, aggressive medical management of the heart failure, or in some cases, surgical options if necessary. All right, so this case really highlights the importance of early diagnosis and treatment in vein of Galen malformations, especially given how life-threatening they can be if left unmanaged. Thank you for joining me in this discussion. If you enjoyed this breakdown and want to dive deeper into fascinating radiology cases like this, don't forget to subscribe to Radiology Made Easy. And if you want to help support us in keeping this content flowing, check out the Buy Me a Coffee link in the description below. Your generosity helps us keep bringing you these insightful discussions. Thanks again for listening, and I'll see you next time.